What if every breath you took felt like breathing through a straw? That is the reality of millions of people living with COPD, and many don't even know they have it. Hi everyone, I am Beatrice. In this video, I will break down everything you need to know about this silent progressive lung disease. So stick around, let's dive in. Chronic obstructive pulmonary disease, COPD, refers to a progressive lung disease characterized by airflow obstruction. So this disease is an umbrella term for chronic bronchitis and emphysema. Chronic bronchitis has to do with chronic inflammation of the bronchial tubes, while emphysema has to do with destruction of the alveolar, the air sacs. I will look into it more when we look at the pathophysiology of the disease condition. But first, let's look at the mechanism of respiration and gaseous exchange. So normally in a healthy individual, you are stimulated to breathe when the carbon dioxide level in the blood is high. And to blow out that carbon dioxide, you feel the need to take in air. Now during inhalation, as you try to take in air, the diaphragm, which is a major muscle for respiration, is usually dome shaped. It will contract and flatten out. The external intercostal muscles will pull outward, will contract, pull outward and upward. And that will increase the intrathoracic cavity. Allowing through a negative pressure, air will rush in from the outside source. It passes through the airways, the bronchial tubes, and get to the alveoli. Now, when you get to the alveoli, usually blood that is deoxygenated already coming from the heart, passing through the pulmonary artery. This blood is deoxygenated, but it's high in carbon dioxide. So when you get to the alveolar capillary membrane, there's going to be an exchange. Now, through simple diffusion, the carbon dioxide from the blood will diffuse through that membrane into the alveolar. And then the air that you have breathed in that is rich in oxygen will also diffuse into that blood, making it oxygenated, and is returned back to the heart so that it can be pumped to the body for use. Now, once that has happened, the carbon dioxide that has been exchanged through diffusion, the body will need to get rid of it. So you go through exhalation. As you breathe out air, the external intercostal muscles relax and go back to their normal shape. They move inward. The diaphragm also relaxes and assume a dome shape, decreasing the intrathoracic cavity, and the carbon dioxide is pushed out of the lungs and you breathe it out. So that's how it should happen normally. But in COPD patients, they are not driven by high carbon dioxide because normally their body they already retain carbon dioxide, so there is no strive to breathe. They don't feel the urge to breathe when their carbon dioxide is high. Rather, it is low oxygen, what we call hypoxic drive, that make them to want to breathe. Now, the pathophysiology of COPD begins with an exposure to an irritant. That's the first phase. So this irritant, a major one, is from cigarette smoking. And then somebody can also get it from secondhand smoke. And if you work in an environment where you are exposed to some fumes, dust, you are constantly inhaling those particles, or even from strong chemicals, COPD could develop over time. Now, the next phase that will happen will be inflammation. This inflammation is going to be a series of inflammation that will happen over time. The inflammatory response, the body will begin to react. The action of leukotriene and mast cells will lead to increased production of mucus that will block those bronchial tubes, causing it to narrow and become more stiffened. So there will be problem with exchange of air, movement of air, oxygen in and carbon dioxide coming out. And with this, with time, it can affect the alveoli. The alveoli, the air sacs, they are supposed to have a large surface area for proper gaseous exchange. But with time, with those inflammatory response and all that, the alveoli become weakened and lose its elasticity, which is like the third phase. And once they lose the elasticity, there will be limited airflow. So there will be problem with gaseous exchange. So even when blood is being delivered, because blood will still be supplied, which is perfusion. But when you get to that alveolar capillary membrane, there will be problem with diffusion because the capillary surface is reduced and there's loss of elasticity. So there will be poor exchange. Carbon dioxide may not properly diffuse in, and oxygen will also find it difficult to diffuse into the blood. leading to what we call ventilation perfusion mismatch. So with the limited airflow, the patient is going to begin to manifest all the signs and symptoms. Of course, with the low oxygen in the tissue, hypoxia, and low oxygen in the blood, hypoxemia, the patient will experience dyspnea, difficulty breathing. They will be short of breath. They will always want to kind of feel like they want to catch their breath. And they will experience autopnea. They won't be able to breathe while lying down flat. So this is a patient, when you're asking them or you're assessing them, you hear them say, oh, I use so many pillows, lay a lot of pillows before they can breathe because they want to sit upright or something to raise them up to breathe. And another thing is coughing. They will cough because of that mucus that's already built up in the bronchioles and the tubes. And another thing is that they will experience wheezing. When you auscultate the lungs, you hear wheezing and even crackles. Another thing will be cyanosis, which is bluish discoloration. You will notice it around them, all over them, even their mucous membrane, their hands, their feet, their appearance generally will be cyanosed. Before now, chronic bronchitis are referred to as blue bloaters, while emphysema are referred to as pink puffers. But it's no longer used because the way they manifest is no longer representing that and kind of look demeaning, referring to patients as blue bloaters and pink puffers. So it's no longer used, but before now it was commonly used because of that cyanosis that come when a patient with chronic bronchitis, because of those obstruction in the bronchial tubes, and the oxygen is not able to properly get to the tissues and the patient and to the blood, and the patient is looking bluish. And because for emphysema, they are always trying to hyperventilate, try as much as possible to blow out air. And because of that, they may not experience that blue discoloration. So you will see them, they describe them as pink puffer. But it's no longer used. Another sign and symptoms is clubbing of fingers. So when you look at their fingers, you will notice that clubbing of fingers. Another one is barrel chest and tripod positioning. So this one is common with emphysema because in emphysema, the alveolar sacs are destroyed or there's loss of elasticity. So they retain a lot of air in there. They are not able to bring it out. So to help them bring it out, they hyperventilate. And as they hyperventilate, the lungs are inflamed. If you look at a normal healthy person, the anterior posterior diameter to transverse diameter will be 1:2. But in a patient with COPD, especially in emphysema, when you look at them, the anterior posterior diameter and the transverse diameter will be equal, 2:2. So meaning when you see them, the lungs are hyperinflamed because they're always sitting in tripod position, putting their hand on the table, and they are trying as much as possible to force that air that they are accumulating. They are trying to hyperventilate to push it out. With time, their shape will just adjust to that. So that tripod positioning and the barrel chest. And then, of course, activity intolerance, weight loss will be there. They will find it difficult to do anything. Little thing they get tired, they will experience weight loss. To diagnose COPD, the first one is pulmonary function test. Another one is chest X-ray. When they do a chest X-ray, it's going to reveal hyperinflation of the lungs. So the lungs will become hyperinflamed. It will be so big. They will notice, especially in emphysema. Then the bronchial tubes, they will see that clogging and narrowing of the bronchial tubes due to accumulation of mucus. Spirometry is also another one they do to see how much air they're able to push out of their lungs and if they are retaining air. And then blood work also, arterial blood gas is going to show respiratory acidosis, and there will be polycythemia. And that's because that hypoxia, low oxygen in the tissues and low oxygen in the blood, hypoxemia, the body will think that they are not doing enough or the heart will continue to pump more blood. But as they pump this more blood, it's not going to help. They will think, the body thinks that when they pump more blood, trying to compensate, it will lead to increased oxygen, but that is not the issue. So the more the blood are produced, it leads to high concentration of blood. The blood becomes so viscous, so thick. So when they do their PCV, it becomes so high. Management of COPD. First, nursing intervention and teaching. The nurse will be doing a lot of teaching and will be doing some intervention. So you're going to be assessing the patient, you'll be auscultating the lungs and checking the extent of wheezing and crackles. And you'll be assessing them, you'll also be positioning them, put them upright in Fowler's position to help them breathe better. And you are going to be monitoring the oxygen saturation. Now, for patients with COPD, I mentioned it earlier, these patients, they are driven by low oxygen. So that's what we call hypoxic drive. So you want to make sure that their oxygen saturation should be at low setting between 88 to 93%. You don't exceed that. So you be administering prescribed oxygen and you make sure that that oxygen is kept at that low value. You'll be administering some medication, bronchodilators, corticosteroid, and other medications. Then you'll be teaching them some breathing techniques like pulse sleep breathing, even diaphragmatic breathing. So for pulse sleep breathing, you're going to tell them when they are trying to exhale, they should do as if they are blowing a candle, something like this. So it will help them to expel as much air out of those lungs because remember they are retaining air, there's air trapping. For diaphragmatic breathing, you tell them to place one hand on their chest, one on the abdomen, and when they open their mouth, they should breathe in through their nose and breathe in deeply. When they're about to breathe out, they should breathe out through their mouth and also involve pulse sleep. As they do that, they will feel that their diaphragm, that major muscle of respiration, doing the work so that they won't be, because they use accessory muscle of breathe to breathe. But you want to encourage them as much as possible to use their diaphragm to breathe. So when they place their hand on the abdomen and they take in a deep breath through their nose and breathe out using pulse sleep method to breathe out through their mouth, they will be using and exercising their diaphragm. So you teach them that. Another thing is high calorie and protein diet. Remember they will experience weight loss, so they will need to eat high calorie diet and eat high protein diet. Now when they eat, they should eat small frequent meals. They shouldn't eat too much because once the stomach is too full, it's going to worsen the diaphragm that is already displayed, that is already flat. So encourage them to eat frequent meals but in small amount, and they should rest in between meals. Fluid intake is encouraged that they take up to 3 liters of fluid, except they are on restriction. Let's say they have heart failure and any condition that make them to take any much fluid. So that's the only condition they won't take fluid. Otherwise, they should take as much fluid as they can, up to 3 liters, to help thin those mucus and help them to expel it out. Another thing, you have to teach them things to avoid. Now they're going to teach them to stop smoking, to avoid secondhand smoke if they live around where people smoke. Another thing, teach them to avoid sick people, to keep their immunization up to date. They should make sure their COVID vaccine, flu shot, pneumococcal vaccine, they are all up to date, because sickness is another thing that can trigger this exacerbation of COPD. And they should avoid extreme weather conditions, especially extreme cold, because it can trigger COPD. They should avoid gas foaming food, anything harsh perfume, any irritant, anything that can irritate those airways. They should try as much as possible to avoid it. Next is medication. So for the medication, the patient will be on bronchodilators, corticosteroids, and there's also another medication we call phosphodiesterase inhibitor. We call it roflumilast. So this one is used especially in severe COPD cases. I discussed bronchodilator and corticosteroid when I was talking about asthma medication. So you want to check that out. But just to kind of throw more light on it or to make reference to it, they will be on both short-acting and long-acting bronchodilators. The short-acting will be when they are experiencing that exacerbation. The long-acting will be for maintenance purpose. And the corticosteroid is going to help with the inflammation, to decrease that inflammation. You are going to teach them when they place them on both medication, both corticosteroid and bronchodilators, they should use their bronchodilator first. Wait 5 minutes before they use their corticosteroid inhalers. And for the bronchodilators, if they are prescribed more than one, they should take the first bronchodilator, wait a minute before they repeat the process. And also, you also be teaching them about side effects of some of this medication. Like for the bronchodilators, if it is beta agonist, you'll be telling them about increased heart rate, tremors, agitation, anxiety. They could experience something like that. And for corticosteroids, they could experience things like osteoporosis. They could even experience cataract. They could experience hyperglycemia. So you'll be teaching them some of these things. And oral trash. So when they use corticosteroid, they should rinse their mouth and spill out the water to decrease the risk of development of infection like oral trash. And for roflumilast, they could be at risk of suicide. There's increased risk of suicide. So you'll be teaching them of some of these side effects. Now for the complication, the right side of the heart will be mostly affected. They could experience right-sided heart failure, what we call pulmonary. They could experience pulmonary hypertension because of that increased pressure in the pulmonary artery, the blood trying to flow back towards the right side of the heart, it could lead to that hypertension, and it could experience respiratory failure. So these are some of the complications of COPD. So that wraps us today's topic on COPD. If you find this video helpful, please like, share, and subscribe for more educational content. Thanks for watching.